it looks like we're at the top of the hour. Good afternoon, everyone, and thank you for joining the Superior Health Quality Alliance Roundtable, which is our conversation around the COVID-19 vaccine and its immune response. My name is Jerry Henniker, and I'm joined today by my colleagues Kelsey, Kim, and Kristen, as well as our guest speaker, Dr. Matt Binnicker. For those of you who have been joining these meetings over the past few weeks, welcome back. We love having you. And for those of you who are new to the call, we're glad you're here, even though it is for the first time. Just a reminder, we host these sessions each week. They are 30-minute education sessions where we highlight important topics related to the COVID-19 vaccinations and their boosters. We hope that you'll be able to continue to join us each week for these sessions. And hopefully you all received the email from us yesterday that announces the continuance of these sessions through the remainder of 2022. All you have to do when you get that email is add those new dates from July 13th through December 28th of 2022 to your calendars. Same day of the week and the same time that we've been doing them previously. Just a reminder, there will not be a session next week on July 6th. As you listen to our session today, we ask that you think about any pebbles in your shoes. So what are those things that you're struggling with or that you're trying to figure out? As you think of these things, send us a direct message in the Zoom chat. That way we can add it to a topic for a future session. We love to hear from you, what your concerns are, and what we can help you with in the future as we do other sessions. You'll find the link for the PowerPoint to today's presentation in chat. Also, towards the end of our session today, we'll add the evaluation link in chat. And we ask that you take just a few minutes to complete this. It's always helpful for us to hear from you about these sessions, what was helpful, and maybe what wasn't helpful, and what should we do for future sessions. Also, please use the chat box to share any of your comments or questions or anything else that pops into your mind during our presentation today. We will take your questions at the end of Dr. Binnicker's presentation. In addition, we will have time available at the end of our session for discussion. With that, I'd like to introduce you to our speaker, Dr. Matt Binnicker. Dr. Binnicker is the Director of Clinical Virology at Mayo Clinic in Rochester, Minnesota. He's a professor of laboratory medicine and pathology at Mayo Clinic and serves as the Vice Chair of Practice in the Department of Laboratory Medicine. His laboratory was one of the first in the country to offer testing for COVID-19, and Dr. Binnicker served on multiple advisory boards for healthcare organizations and companies to assist them in COVID-19 testing and safety protocols. Welcome, Dr. Binnicker, and the floor is yours.
Great. Thanks, Jerry and Kelsey and Kim, for inviting me to participate in this call. Glad everybody could join, and understanding that this group focuses on COVID-19 vaccines and safety protocols. We wanted just to give you an update on some of the other tools in our toolbox to keep healthcare organizations, including nursing homes, safe throughout the COVID-19 pandemic. So I'm going to talk a bit today about testing, provide some updates on where we're at, where we've been. Also going to address the topic of COVID-19 variants and also touch on how the development of new strains of this virus will impact our ability to plan for future vaccinations and boosters. And I'll definitely leave plenty of time for question and answers. I'm sure there are probably things that you're grappling with and would like to bring up. So we'll leave plenty of time for that. So before I begin, just wanted to mention I'm an advisory board member for a few diagnostic companies, DiaSorin Molecular and Mammoth Biosciences, but won't talk about anything related to their products today. So really the objectives for the next 30 minutes or so will be to describe how testing for diagnosis of COVID-19 has evolved over the last 2.5 years. We'll also discuss the potential impact of SARS-CoV-2 variants on transmission of the disease, vaccine efficacy, but also the potential impact of new strains of the virus on testing. And then finally, I'll wrap up by talking about some of the new advancements that are coming out that may improve our ability to diagnose this viral infection in the future. So I think it's always interesting to talk about this family of viruses and how different strains have evolved and emerged over the last several decades. You probably are very familiar that there are strains of coronaviruses, and I've listed the four common strains here that circulate in the population and cause epidemics of the common cold. And so we've lived with these viruses for decades, and we have seasonal epidemics here in the United States of the common cold. Usually that's most prevalent in the winter months. And this is something that the population and healthcare professionals doesn't think much about because it's become so common. And these viruses that are listed on this slide typically cause mild to moderate illness. There are situations in the right host, if they have a compromised immune system where disease may be a bit more severe, but overall, minor illness that's self-limited usually comes and goes in a period of 7 to 10 days. But within that same family of coronaviruses, what we've seen over the last 20 years is three strains of the virus emerge that have been associated with more severe disease. The first outbreak was in 2002 and went on for about 12 to 18 months, mainly isolated to Asia. And that, of course, was severe acute respiratory syndrome coronavirus. Now, that virus has not been in circulation over the last 20 years. So it emerged, it caused an outbreak, again, mainly geographically isolated to Asia, and then has in large part disappeared in the human population. About a decade later, in 2012, there was another coronavirus strain that emerged. This one first started causing cases in the Middle East and subsequently was given the name Middle East Respiratory Syndrome Coronavirus, or MERS. MERS had a mortality rate that was higher than the original SARS virus. And MERS has caused sporadic outbreaks over the last 15 or 20 years, but hasn't resulted in a large pandemic like what we're experiencing now. And of course, in late 2019, early 2020, we began to see an outbreak initially in Wuhan province of China of what has been named SARS-CoV-2. So it's a family member or a relative of the original SARS virus. But this one had properties that led to greater transmission among humans, and has resulted, of course, in the COVID-19 pandemic that we've all been grappling with over the course of the last 2.5 years. So when COVID-19 first hit, a common question that I was getting was, why do certain coronaviruses like SARS, MERS, and SARS-CoV-2, why are these certain strains more associated with severe disease in comparison to other strains like the 4 coronavirus strains that I first showed? Well, these are zoonotic viruses, meaning that they originate in animals. And that's typically thought to be the natural reservoir for these viruses. So those common cold coronaviruses may have originated from swine or cattle, whereas these more recent coronaviruses that have resulted in these outbreaks of severe disease are thought to have arose from bats. So in 2003, the original SARS coronavirus, a lot of studies have been done showing that virus is likely hiding out in bats, and then crossed over into the civet cat. And you can see an image there on the slide. And then interaction of people with that animal resulted in transmission or spillover into the human population. In 2012, with the Middle Eastern Respiratory Syndrome, coronavirus. It was likely transmitted from bats to camels, and then interaction of people with camels resulted in spillover of that particular virus into the human population. And then with this particular more recent strain of SARS-CoV-2, that also is believed to have a natural reservoir of the bat population, but it was believed to have been transmitted from bats into animals like the pangolin, which is that cute critter in the bottom right-hand side of your slide, or turtles. And so interaction of people in wet markets with animals such as the pangolin or the turtle resulted in spillover into humans. Now, why more severe disease? Probably characteristics of the virus itself. So has certain pathogenesis factors that results in more severe disease, but also immunity. So it's likely that the human population had not been exposed to a virus like this, and so had no pre-existing immunity. And so the virus is better able to be transmitted, but also result in a more severe disease outcome. So, of course, beginning in 2020, when the COVID-19 outbreak and pandemic began, all focus was on ways to identify positive cases. And so there was a significant amount of attention on developing testing for COVID-19. The first group here in the United States that was able to offer testing, of course, was our public health infrastructure with the Centers for Disease Control developing a test for SARS-CoV-2. They worked with their laboratory response network, or the LRN laboratories. Those are really our public health state labs, to roll out that particular test. And then clinical labs and reference labs began to bring on tests. We started our testing journey on February the 15th of 2020 and made the decision that we needed to have a COVID-19 test up and running in 3 weeks. And we pulled together a team of 15 people who worked night and day. And by around March 10th, March 11th, we started testing for COVID-19 right about the time that the disease started to be present in Southeast Minnesota, where Mayo Clinic is located. Our laboratories have now performed millions of COVID-19 tests and, of course, detected and diagnosed tens of thousands of cases, mainly using that technology that we've all become familiar with over the last 2.5 years, which is PCR. So looking for the virus's RNA or nucleic acid in samples like a nasal swab. Shortly after that, maybe a few months into the pandemic, there was interest in the use of antibody tests. Could antibody tests be used to figure out whether someone had been exposed and is now immune to infection? Well, we have a good understanding now that yes, antibody tests can be helpful in determining whether someone was exposed or responded to vaccination, but that a positive antibody test doesn't necessarily mean that someone is immune or protected from reinfection in the future. And a negative antibody test doesn't necessarily mean that you are completely susceptible, because those antibody tests are looking just for one part of the immune system, which is antibodies. We know we have T cells that are important to our immune system as well. So they're an important tool, but maybe not the silver bullet in terms of giving immunity passes that we were, initially talking about in April and May of 2020. There was then development of what I call rapid molecular tests. So these are tests that we could actually put into a nursing home or an emergency department, where you can get a PCR-like result, but in like 15, 20 minutes. And so companies were developing these, and these have been used, of course, in many healthcare settings across the country. The problem is they can't handle as many samples as the types of tests that are offered in most clinical labs that are better set up to handle the large number of tests that we've had to deal with throughout the COVID-19 pandemic. Of course, rapid antigen, that's kind of where the focus has been over the last 6 to 9 months, is use of these antigen or protein-based tests that I'm sure all of us on the call have done at least one of these. Easy, fast, can give a result, and if it's positive, typically reliable. The problem is we'll discuss, a negative result doesn't necessarily rule out that you could be infected with this virus. And of course, at-home testing. And now there's numerous options available to us. We can go to the drugstore, pick up one of these. The government can even send them to you free of charge. And now we have these at-home antigen protein-based tests. And in some situations, companies are developing more PCR-based tests that can be performed at home. And I really think this will be, in some ways, the wave of the future, not only for COVID-19, but for other diseases, and especially infectious diseases in the future. So really what we've seen is this evolution from very centralized testing model, samples having to be sent first to the CDC and then to only a few reference labs in the country, which was resulting in longer turnaround times for you getting your results, to a very decentralized testing paradigm, where we think that today 60 to 70% of all the COVID-19 tests that are being performed each day are done outside of a clinical laboratory. 60 to 70% of testing being done likely in people's homes. That's good, but it's also something to raise maybe some cautions, because we're not capturing the number of cases like we were from a recording and public health perspective. We're also maybe missing an opportunity to connect patients with their healthcare professional for management and treatment decisions if they're not contacting their physician or nurse with the results of their test. So I'm just going to briefly give some updates on the different types of tests and kind of what we know about those tests. So again, we're going to start with what's been considered the gold standard, or the most commonly used test, which is those PCR tests. There's more than 240 tests that have received what's called emergency use authorization, or EUA, from the Food and Drug Administration. So no shortage of tests that are available that fall into this category. We've learned a lot about use of these tests, mainly that if you perform one of these tests early on in an individual's disease, so if they've had symptoms for a few days, 3 to 5 days, that's when that test is going to have the greatest chance of being positive. If you perform a really sensitive molecular test like PCR the day after someone is exposed, even if it's a great test, it's not going to be positive, because it takes the virus some time to reach levels that any test will be able to pick it up. Also, the ability of that test to be positive depends on, of course, when we would collect that sample, what type of sample we collect. So we've learned that there are differences between a swab of the throat, a swab of the front part of the nose, a swab of the nasopharynx, all differences in how much virus is present in those different parts of the body. How well the sample's collected. We've probably heard stories about the swab just going in and touching the roof of the mouth or the top of the nose and not being vigorously swabbed. I've even heard some friends talk about trips to Mexico where they would go in to get their test to come back to the US, and the nurse or the person collecting the swab would touch the top of the roof of their mouth, and that was their collection. Well, a negative result in that situation, probably not too useful. We really need to get a good quality sample in order for that test to be most meaningful. And of course, there are differences in the tests too. With over 240 tests, they're not all going to perform the same. We've also learned that with these molecular PCR tests, they can stay positive for weeks and then sometimes months after someone has COVID-19. We have some of our immunocompromised patients here at Mayo, transplant recipients, who may test positive for 6 months after a COVID-19 diagnosis. Now, that could just be the virus's RNA is hanging out and not being cleared by the body for a long time, in some situations, the virus can actually remain replicating and infectious for longer periods of time in some people. So because of this, we don't recommend that these PCR tests be used anymore to discontinue isolation, with the exception of certain immunosuppressed patients that may shed the virus for longer periods of time. So here's an example of the first at-home molecular test. This is something that you can go to Walgreens or CVS and pick up or order online. So again, this is a molecular PCR style of test, even comes with its own battery in the package. Everything you need to do the test is in that box, and you can get a really high quality sensitive result from the comfort of home. So the antibody-based tests, there's more than 75 of these that have received emergency use authorization from the FDA. And as I talked about, there was a lot of interest in using these as immunity passes after a diagnosis of COVID-19. But we've learned, of course, that even if you're antibody positive, it doesn't mean that you can't be reinfected. So some of the lessons learned from this is that an antibody-based test really isn't very helpful if you perform that test within about a week of a person developing symptoms, because it takes time for the antibodies to develop, usually a couple weeks. By day 15, after a person develops symptoms, antibodies are there, and these tests will pick up those antibodies in almost all cases. Now, some patients who are exposed to the virus but don't develop any symptoms may not generate as high a level of antibodies. So we've learned that typically the more severe a person's illness, the stronger their immune response. So asymptomatic individuals who were infected may have a negative antibody test. And so they have limited to no kind of role as an acute diagnostic test, mainly because of the time it takes for these antibody-based tests to become positive after someone's exposed. What about the rapid kind of at-home antigen test? So these tests are looking for a viral protein instead of the viral RNA. And there are dozens of these at-home antigen tests that are approved. I think the take-home message for the antigen-based tests is that they perform pretty well during the first week of symptoms. So if someone has symptoms, cough, sore throat, fever, and it's early on in the disease, those antigen tests work pretty well. Their sensitivity is pretty reliable. But if you start to think about testing asymptomatic individuals, in other words, I went over to some friend's house and I found out a friend of mine had COVID that I was exposed 24 hours ago. I don't have any symptoms, but I'm going to take an antigen test. That negative result that you're likely to get doesn't mean that you weren't infected. The sensitivity among asymptomatic individuals, so those without symptoms, can range between 30 and 70%, depending on the study. So really almost a flip of the coin in that population. And when we're using antigen tests or protein tests, you almost need to perform them what we call serially, multiple times per week, to ensure that the results are accurate, because it all depends on where an individual is at in their infection cycle. Did we test while the virus was still really low and kind of incubating? Did we catch them when it was really high? Or did we wait too long and now the virus is starting to clear? And so that's why testing multiple times per week will help us pick a patient up when their amount of virus is high in their respiratory tract. There were a lot of concerns early on about what we call the specificity of these tests. In other words, how likely are they to cause false positive results? Fortunately, the specificities turned out to be pretty good. So the number of false positives appears to be relatively low. Still can happen, but not at a really high rate that we were worried about. I did just want to briefly touch on this technology that we call sequencing. So this is actually determining what the composition of the virus's genome is, and it allows us to say, did this person have a strain of the virus that was the same as another individual. There's a few assays or tests that are sequencing tests that have received authorization, but these take quite a while to get results back. And so they're not used as a diagnostic test. They're really used to help follow up on outbreaks. For example, if you had an outbreak of COVID-19 in a nursing home facility, you might use a sequencing based test or request that sequencing be done at like a public health laboratory to find out if they were all the same strain, or was there one individual who seemed to be kind of the index case resulting in spread through a whole healthcare site. That's how sequencing is used in hospitals and other settings. So really more of an epidemiologic tool for outbreak investigation rather than a diagnostic test. So this is a table that just kind of summarizes the various types of tests we just talked about. So turnaround time is how fast you can expect to get those results back. So PCR-based tests are molecular, typically within a day, and sometimes based on the test, you may get those results back in 30 minutes or an hour, depending on whether a site's using a rapid PCR. Of course, antigen tests you can perform at home, maybe 15, 20 minutes to get those results. And I've indicated in that second row whether the testing is used for diagnostic purposes. So really it's the PCR and the antigen tests. Again, the main benefit of serology is to identify whether someone had been previously infected. Doesn't mean that someone is immune. It just means that they've been previously exposed or vaccinated, depending on the serology test. All right, so we'll stop there with the testing and move our discussion now into the topic of variants or different strains of SARS-CoV-2. So let's start by highlighting that this particular virus has a type of genetic material, or its genome, that's made out of what's called RNA. So there are viruses that have DNA genomes, and there are viruses that have RNA genomes. Another virus that has an RNA genome is influenza, or the flu. And viruses that have an RNA genome are more likely to have errors incorporated into their genome as they're making new copies of the virus. I kind of liken it to a young child who's just learning how to write. They don't have very good proofreading, so they'll write out a sentence, but they'll incorporate a number of mistakes into the sentence. That's what RNA viruses are like. They can copy their genome, but they don't have as good of proofreading capabilities. That's why with influenza, we have to get an annual vaccine, is because the virus, the influenza virus that's circulating in 12 months will be a different virus than what's circulating today, because the virus is undergoing lots of changes in its genome over that period of time. The same thing is true with SARS-CoV-2. It makes copies of its genome, it makes mistakes, it changes over time. Now, most of the time, those mistakes or errors don't result in the virus behaving any differently. It doesn't change the way that it's spread. It doesn't change the type of disease it causes. It doesn't change our immunity to it. But once in a while, it does. Once in a while, a new type of virus emerges that spreads a lot more efficiently from person to person. Once in a while, a virus emerges where the proteins on the surface of the virus look differently than viruses in the past, and maybe our antibodies don't recognize that virus as well. Or maybe a virus emerges that causes more severe disease. So that's a rare occurrence, but when you talk about millions and millions of people being infected, the chance of those rare occurrences happening increases. So, as I mentioned, in some cases, those variations or changes in the genome can result in increased transmission, increased disease severity, or maybe reduced efficacy of our vaccines or our therapeutics like monoclonal antibody treatments. Also, there's a good question of whether lab tests could be impacted by these SARS-CoV-2 variants? Is it possible that these mutations that happen over time in the virus's genome, is it possible that those could impact the ability of our testing to pick up an infection? Now, fortunately, most of the tests that have been used throughout the pandemic have been those PCR tests. And the companies that make these tests knew that this was an RNA virus. And so they built in kind of a built-in redundancy or backup system. So we're looking for multiple parts of the virus's genome instead of just one. Why is that important? It means that if there were changes in one part of the virus's genome, there will be a different part of the test that's looking for a different area. And hopefully that combination will still allow the test to pick up the virus, even if there's been mutations. Now with antigen tests, these at-home assays that we're using, they're looking for viral proteins, and they're probably more susceptible to being falsely negative if a virus's protein changes some from mutations. But so far, I think we've been pretty lucky, and the antigen tests have shown that they can pick up these new SARS-CoV-2 variants with pretty good reliability. And companies in the FDA are continuing to look at these new strains and ensure that our testing will work. Now, as at-home antigen tests started really getting popular, and as Omicron started to emerge, people started to say, you know what, with Omicron, there's more sore throat. And so maybe we need to take a throat swab instead of a nasal swab. And then there were social media posts about, hey, when I did a nasal swab, it was negative, but when I did a throat swab, it was positive. So I think you should only use a throat swab. There was all these stories on Twitter and Facebook and Instagram about this throat swab testing. I just wanted to spend a slide on this to say that's not currently recommended, that these tests are all studied and validated with nasal swabs, and that's how they should be used. And the reason for that is that the pH, or the acidity level, is different in the nasal passage versus the throat. We eat, we drink, and so the pH is probably going to be a bit lower in our throat than it is in the nose. And if it's a more acidic environment, these protein antigen tests are more likely to be falsely positive. Okay. And this even was discovered by kids in the United Kingdom. There was a story last year of kids learning about, hey, if we stuck the swab in some Coca-Cola and then used that to inoculate the test, we could get a positive result. And then, hey, we can get out of school. And so there were kids in the United Kingdom who were triggering their antigen test to be positive by using Coca-Cola because it's a very acidic drink. So that's just a story about the importance of making sure that we're collecting the right type of sample for the different types of tests. So in the future, when we start to think about different diagnostic tests, I think we're very, very likely going to see an emergence of more at-home diagnostic tests. COVID-19 has really accelerated that. As I mentioned, maybe 60 to 70% of all the tests that are being done today are at-home antigen tests. I think we're going to see more antigen at-home tests for sexually transmitted infections like gonorrhea, chlamydia. I think we'll see more respiratory viral infections being diagnosed at home. Of course, they have advantages. We like speed. We like to get an answer in 15 to 20 minutes. They're pretty easy to use. Usually it's just a swab, drop in some buffer, insert the swab, and you get your results. But I always like to tell people, when you have speed and ease of use, you're usually sacrificing somewhere. And a lot of times that's accuracy of results. So we know that in individuals who don't have any symptoms, that accuracy really suffers, and the sensitivity is usually about 40 to 50%. Tends to be better in individuals who have symptoms, maybe in that 80% range. So because of that impact on sensitivity, if you get a negative result, doesn't rule out that you don't have COVID-19. Again, if you've got symptoms and it's positive, that's pretty reliable, but a negative result really only means I'm probably not shedding high amounts of the virus at the time I take that test. 6 hours later, 8 hours later, for sure, 24 hours later, it could be a completely different story. Positive at-home results, if you have symptoms and you get a positive result, pretty likely you've got COVID-19. Now, I think it's important in the future that we make sure that these positive cases are tracked, either by notifying public health or notifying your physicians. And then the other component to notifying a healthcare team member is to make sure that a person is managed appropriately. Some people will really benefit from COVID-19 treatment, whereas others don't need it. So getting a positive at-home antigen test is useful, but making sure that we contact physicians, give them some information about the patient so that there can be a determination whether they'll benefit from treatment or not is still really important. What are some things that we might see in the future? Of course, a lot of work and innovations taken place over the course of the COVID-19 pandemic. There are a few companies that have developed breath analyzer tests, where you basically breathe into a device like that shown here on the right-hand side of the slide. And in just a few minutes, it can give you an answer of whether you're infected with a respiratory virus like COVID-19 or not. We might see that in the future in settings like airports and buildings where there are lots of people, like sports arenas. There's a technology called CRISPR that you can read about. It's kind of the latest and greatest thing in terms of genetic alterations and diagnostics that might be used with things like our smartphones to help give us diagnostic answers from the comfort of home. And yes, there's even been studies on using man's best friend, our dogs and pets, to basically be able to detect individuals who are infected with this virus. And it turns out that dogs, when they smell samples from patients with COVID-19, have a pretty good ability to discriminate samples that contain the virus versus those that don't. So again, maybe in the future, there could be COVID sniffing dogs in airports to help pick out people who might be infected and who might warrant by being tested with another test like PCR before they boarded a flight. So just to wrap things up before we open it up for questions, this is a disease that's caused by an RNA virus. That's severe acute respiratory syndrome coronavirus 2. Over the course of the pandemic, we've used PCR a lot, but now we're seeing a lot more at-home antigen testing. There's been hundreds of millions of cases, over 1 million deaths here in the United States. And we have seen variants of this virus emerge, Delta, Omicron, that have shown higher rates of transmission and now even abilities to evade the immune response elicited by prior infection or vaccination. Now, even though we've seen increased rates of evasion from the immune response, we know that vaccination is the best tool to prevent an individual from having severe disease requiring hospitalization. And we've seen, even with the Omicron outbreak, that even though the case numbers have increased, the number of people showing up in the ICU and dying from COVID has really plummeted. So that is the silver lining to this, is that vaccination is and will continue to be a really important tool in allowing us to live with this virus long term and prevent our hospitals and healthcare settings from being overwhelmed like they were in 2020. Most of our tests can detect COVID-19, including the emerging variants, but we'll likely need to keep updating these to ensure that. And the variants can impact test performance, probably more likely on the at-home antigen side than the PCRs. But these tests will continue to be a really important tool in identifying positive individuals. I think it's very likely that we'll see a new round of boosters become available this fall. Of course, the FDA advisory committee is meeting this week. They voted almost unanimously that a bivalent vaccine should become available that would include the original strain of the virus as well as Omicron recent variants. We may need boosters on an annual basis for the next year or two. Whether that will be a long-term requirement or not remains to be unseen. But what we know is that after immunization or even natural infection, the amount of immunity declines, usually after 4 to 6 months. And so just kind of reminding the immune system of these proteins and antigens to help to get that immune level up to a point that it can ward off infection will probably be needed over the next 1 to 2 years. So some reading, if you'd like to dive into some more details on the topics that I discussed. And here was the original team that we pulled together in February of 2020. So again, a team of about 15 people that worked really night and day over the course of 3 weeks to get our COVID-19 test up and running in early March. And just want to thank them and all the healthcare professionals who have battled the pandemic since then. So with that, I'll stop. It looks like we've got about 20 minutes for question and answer. And thanks again for having me here today.
Thank you, Dr. Beneker. There's so much great information that you shared today. And also just thank you for all the work that you and your team at Mayo Clinic has done in this area. It's really appreciated. I'm looking, and Kelsey or Kim, you can let me know too, but I'm not seeing any questions in chat. And maybe I'm just missing them. Okay, so we don't have any questions in chat. And I just want to, we just got a question in chat from Tracy. She says, have you heard much about the development of a nasal vaccine?
Yeah, it's a good question. So the intranasal live attenuated vaccines, of course we've used with influenza. And to my knowledge, there isn't any kind of use of intranasal vaccines for COVID-19 in the near term, likely because there's, concerns about injecting even an attenuated live virus of this kind. The benefits of the nasal vaccine is we're injecting an actual virus rather than just a part of a virus or something that's going to make one viral protein. So the immune system gets to see all the different types of the virus and all the proteins. So there can be some better protection that's provided, but especially in individuals whose immune system may not be as strong, even a live attenuated virus can cause problems. And so that's probably why it's not become as widely studied and used. Good question though.
And I see here that she'd added that it seems like it would be a better defense mechanism, but I think you alluded to that, Dr. Beneker. Yep. Does that answer your question, Tracy? Great. And as Kelsey put in chat too, if you have any questions, you can certainly enter them in chat, or else you can just take yourself off mute and ask Dr. Beneker directly. I also want to pull Kristen Bosch into the discussion now, as I know that she's developed a few questions to aid in our discussion here at the end of the session. So Kristen, if you want to take yourself off mute.
Hi. I guess my first question, I thought maybe some of the members here might be wondering the same thing for Dr. Beneker. Why is it that we see the prolonged shedding of the RNA of the virus in immune compromised patients over other patients?
Yeah, it's a really good question, Kristen. So the thought is that in those who don't have a typical or normal immune system, that the virus itself may not be cleared as quickly, or that parts of the virus, including its genome, after a virus may break down, the immune system isn't to the level that otherwise healthy people are that would go in and clear up those pieces of the virus as fast. So in some patients, we think they can actually be infected and infectious for several months.
Okay, and that was my next question of just, when you're looking at nursing homes here and perhaps having to, close off a wing or,
Yeah.
whatever it is, because you might have an outbreak, should that be for a longer period of time that we're, keeping those infected individuals isolated so that we aren't risking the spread amongst the facility?
Yeah, it's a really important point. And I would say that the Centers for Disease Control COVID-19 website and resources has pretty good guidance on testing in those with a normal immune system versus those with a compromised immune system. And yes, typically in those who don't have as strong of an immune system, so cancer patients, transplant patients, those with that are on steroids or other immune modulating drugs, they may have to be tested for longer periods of time because they can shed or be infectious for longer periods.
And that was one thing in my own experience. As a former dialysis nurse, I was seeing that patients were definitely continuing to test positive in the PCR testing quite longer.
Yeah, for sure.
So then I guess my question to the members here listening in is, what have you been noticing within your residents patient load of how long that time, that, kind of magic number of time frame? Because I think when we get into the geriatric chronic conditions, as we see in, a lot of our residents, that they tend to have some of more of those immune compromised or chronic conditions that might be more lengthy in like the disease process. So what have you guys been using as your protocols for the time period that you're perhaps isolating them or trying to help prevent the spread of infection?
And so in response to, if you're answering Kristen's question too, you can just put your answers in chat, or if you want to take yourself off mute to discuss, you can do that too. While we're waiting for people maybe to answer your question, Kristen, in chat, I see, or we did get another question. What are your thoughts on quarantine guidelines for new admissions that are not up to date on COVID vaccines? Are they reasonable? And it is kind of interesting. I don't know if Dr. Binnicker, if you heard our discussion prior to this call, we're talking about how there's different definitions of up to date.
Yeah, that is a challenging area, and that some groups consider up to date just receiving the primary series, other one booster, other multiple boosters. So it gets to be challenging. I think based on the data that we have available, the rate of someone being infected and especially becoming symptomatic is lower in those that have had their primary series and at least one booster. Of course, people can still be infected and even have COVID-19. We're starting to see that a lot more frequently, but their period of time where they're transmitting the virus tends to be shorter than those who are especially non-vaccinated or have just received their primary series. So the amount of quarantine time, I think rightfully so, can be shorter in those that have had primary series plus the recommended number of boosters. Looks like there's another question here about in long-term care center. We had a secondary group of infections due to a cancer patient remaining positive beyond 20 days. And we now require 20 days and a negative antigen test prior to discontinuing isolation precautions. Yeah, I think it's reasonable for sure, especially in those who are immunocompromised, because we know that they can shed the virus and be infectious for longer than the typical 8 to 11 days, 14 days that we're requiring in most individuals. So that approach makes sense.
And another question for the members here, what kind of information, we had a lot of great information on just how all of this evolves, the different testing, and a lot of things I'm sure that we know as healthcare individuals, but that sometimes our staff members or residents, their families may be questioning. So what type of information are you sharing to help explain some of that material that was presented today? And perhaps you're sharing it with your staff members, your families, residents. Is there something that you've found to be successful in sharing that perhaps others would like to use?
I think the information I covered was either put everybody to sleep or confused everybody, or maybe answered all the questions.
Perhaps.
Dr. Binnicker, this is Kelsey, and I do have a sort of future question for you. So if you had a crystal ball and we're looking like 10 years from now, what are your thoughts about an annual COVID vaccine similar to like what we have currently for the flu? I mean, is that something that we think is a possibility, or what's kind of the general feeling on that at this point?
Yeah, I think it's likely over the next few years. I think as we start to get out a decade from now, I would guess that we probably won't be requiring annual vaccines for COVID-19 in a decade. At least that's my hope. I think that it will start to be more of a common cold virus than it will be a type of disease that results in really severe disease like we've seen over the last couple of years. I think as that kind of baseline level of immunity increases from natural infection and several years of vaccination, that the severity of the disease will start to decrease to a point where we don't need to have those annual vaccines. But I wouldn't rule out the possibility, but I think hopefully in 10 years that will be less likely. I don't think that COVID-19 will go away. I think that we will continue to have to test for it and have that, in our differential of people with a respiratory disease for years.
I have a question, Dr. Binnicker. In regards to, before you know it, we're going to have the flu season is going to be upon us. And so many times influenza and COVID-19 could possibly, mimic each other. What do you have? What do you have? The flu or COVID? Are there going to be, or do you think that like, especially nursing homes would have these quick like PCR tests for influenza, since it is a RNA type of virus as in like COVID is? Is that something in the future possibly?
Yeah, for sure. There already are some options for quick PCR tests for flu, and there are even some tests that are available that can test for both influenza and COVID all in the same test. And that can be really helpful to determine whether someone has COVID, flu, to differentiate, because of course our flu patients need maybe an antiviral like Tamiflu, whereas COVID patients might benefit from different types of therapies. So I think in the future, we'll see more rapid tests become available and tests that can pick up and differentiate between flu and COVID.
Thank you.
So we did just put the eval link in the in chat. We also do have another question. How long do you see long-term care workers wearing PPE and eye protection? This creates hardships and barriers in so many ways.
Yeah, it's a great question. I think we're going to start to see de-escalation of PPE, like masking and eye protection, but it's going to be phased through different parts of society and healthcare organizations. So those who are interacting with high-risk patients, the elderly, those that have immune compromised, those are the components or areas of healthcare where you're going to probably be required to wear PPE masks and eyewear for the longest period of time, just because of the risk associated dealing with those individuals. Whereas I see, de-escalation of masks and other PPE and other parts of healthcare, those that are interacting with young, otherwise healthy children, those that don't have direct patient contact, we'll start to see declines in usage of masks and eye protection in those areas. So yeah, I mean, I hear it from my lab staff all the time about the burden that it places. And I think we need to start to move in that direction, but we're not quite there yet in terms of being able to go back to not wearing a mask in areas where we're interacting with high-risk patients.
And perhaps maybe part of that will become the shift in the viewpoints of, say when you enter a surgical role, you just know that that's a part of your job. When you are in surgery, you are masked up, you have that extra PPE layers of protection, and it comes with just the grounds of the work you're doing. It's accepted. No one's saying, hey, I don't want to wear a mask anymore when I have to go into the surgery room and perform an operation. That, it just might become more of that acceptance of this is my job and I'm working with my high risk individuals, immune compromised, chronic illness type patients that need that extra layer of protection for their own health.
Not seeing any other questions in chat. I did want to thank Stacy. I think she was responding to your earlier question, Kristen, where she said that she tries to remain available and meet people where they are when she's providing education. Kristen, I didn't know if you had any other questions for our discussion that you wanted to pose to the group.
I guess the last one, I just wanted to ask if anyone's facing any challenges with getting testing for whether it's their staff members, residents.
As you're all contemplating that question and putting your comments in chat, I just wanted to remind everybody that we, again, Kim did put the evaluation link in chat. And so we really do appreciate your feedback. It helps us with our future sessions and for our planning. So as we're closing out, again, if anybody has any comments, feel free. Oh, they have one. Tracy has a very big challenge, more and more resistance out in the field is what she's seeing. So thank you for sharing that, Tracy. See, we have just a few more minutes to the top of the hour. Please feel free to put questions or comments in chat. I'm just going to kind of close us out here. Just a reminder, have a wonderful 4th. We'll see you all in 2 weeks on July 13th for our next session. I want to again thank you, Dr. Binneker, for your presentation today. It was very informational and just a wonderful presentation. Thank you for being here with us. And with that, I am going to close us out. Everybody have a wonderful holiday weekend and a safe holiday weekend. And we'll see you all, as I said, in 2 weeks.